Matibabu ya ugonjwa wa saratani. Gavana Muthomi Njuki, wewe ni mwenyekiti wa ile kamati ya magavana ambayo inahusika na masuala ya afya, na kulingana na maelezo ambayo wanaeleza hapo wale ambao wamewahi kuugua kansa, changamoto kupata matibabu ni changamoto ambayo ni kubwa sana. Je, inawezekana kwamba katika ngazi ya kaunti, kwa mfano kama wewe ukiwa katika kaunti yako ya Tharaka Nithi, unaweza kushikana na yule mwenzako wa kaunti ya Meru ili mubuni ama muwe na kituo kimoja ambacho kitasaidia wagonjwa wa kansa, kwa sababu gharama ya kuweka hivi vituo imebainika wazi kwamba ni gharama kubwa sana, na kulikuwako na mipango ya kila kaunti kuwa na kituo, lakini changamoto ya fedha pia inabainika wazi kwamba ipo. Je, inawezekana kwamba kwa mfano Meru na Tharaka Nithi mshikane muwe na kituo kimoja cha kuwasaidia wagonjwa wa kansa?
Kubali ni jibu na kizungu kidogo, Kiswahili ni changamoto.
Hakuna tatizo.
Yes, I've listened to the survivors and really I feel for them, especially about the issue of the stigma, and we should not be the case. And I've always listened to those who go very long distances seeking for treatment. And I want to put it open that putting up a cancer treatment center, comprehensive, where you walk in and you are diagnosed and you're given treatment and you go back, and you know, cancer treatment is not one-off. Sometimes it takes even a year, it takes 6 months. It is a very costly affair. You cannot put up one unless you have something in the tune of 600 million. Let's look at the county of Tharaka Nithi, for example, because I don't want to use other counties as examples. My health budget, without looking at the workforce, is around 300 million for everything: drugs, equipment, commodities, and everything else that revolves around treatment. If my whole budget is 300 million, it would mean that for me to build a cancer center without any aid from the national government, from any donors, then I need to close my hospitals for 2 years and eliminate any other service and save 300 million for me to be able to build a cancer center. However, there's something I'll be able to do. If it was possible to have regional centers that are supported by national government, and we have an arrangement where we can have a contribution from the source for those counties around there, it is possible to put up a cancer center, which then we can be able to second the oncologists there or the doctors or personnel that are required, which brings me to the issue of the availability of the same. It is important to mention now that the professor of the University of Nairobi is here. We have a serious shortage of oncologists on all cadres in Kenya, from the specialists of doctors, from the nurses, to the radiologists who are oncologists. We have a big shortage. I was talking to the doctor, to the professor today, and he's telling me we have 66 in the country, and we are looking graduating about 30 of them. That would be about 100. Look at the population of Kenya of 54 million. If we are looking at 100 oncologists, it means that we have a patient to doctor ratio of 1 to 540,000. I don't know where that kind of a ratio is ever found anywhere in the world. And it means that we have to pull up our socks as a country, train more, attract more.
Right.
If there's any program that should have gotten that agency that made us bring the Cuban doctors, it is this one. So that before we get there, then we can actually be able to either fast track in the training or get the kind of arrangement we had with Cuba, so that we can stop talking about machines that are used for diagnosis, which are very expensive also. But the machines cannot work on their own. They need those who operate them and diagnose. And that is, as a county, that is where we have the biggest problem.
Okay.
And allow me to say as I finish that Meli put it very clearly that counties are different levels in terms of putting up cancer centers. The 20 that have been put up have not been put up by counties. That was a program that was put together by the national government just at the event of devolution, and the counties have had their contributions in terms of space, and those are the ones that should be able to serve as regional centers as we increase the others, so that we do not make it look like every county is supposed to have one, so that the electors don't feel like there's some counties that have, others don't have. Right.
And Waziri, talk to us about the overall strategy, especially in ensuring that the treatment, of course, the care for cancer is as widespread as possible to reach the patients closest to their homes. What is that strategy so that even if it's not possible to have 47 centers, counties can have one that is within reach instead of coming to Nairobi and other urban centers?
Thank you, Sam. But let me first of all begin from what I've heard from the people in the other stage in terms of stigma. Many years ago, about 20 years ago, we were in the same space for HIV/AIDS. And we had many programs running nationally about ukimwi unaua, jikinge na ukimwi, you know, and we created a lot of awareness around HIV/AIDS. Yesterday, I met a lady called Edna, who was patient number 2 in the country, and they started on ARVs. And they are able to talk about it, about what they're doing and how they have been able to lead a meaningful life from 20 years ago from their diagnostic up to now. They're on ARVs and they are leading a very meaningful life. What am I trying to say? One is that breaking stigma begins with the patient. Accepting that I have cancer and talking about it. That is stage number 1 of breaking stigma. Number 2 is what we are doing today. Many people do not know that National Cancer Institute is a saga in the Ministry of Health. We are creating awareness about cancer. So then we talk about it and so that many people get to know what is this. Now, I've heard somebody say, how would a CHP be able to check for cancer? In fact, some cancers you can check for yourself, like women, breast cancer. We are taught in many places how to be able to palpate your breast and get to know whether you have a lump or not. And for cancer, you only need to be suspicious. Then you get to the next level of care. Now, to your question of how is it then that we can ensure that Kenyans can access services. One, we must acknowledge as a country that the cost of treatment of cancer or just care for cancer, the inputs themselves and everything that goes into treatment for cancer is not pocket change. It is quite expensive. And we were looking at the numbers. Dr. Meli here has said that we need about 600 million to set up one center. So it is not possible that we can put centers all over. But as a national strategy, we have regional cancer centers. And so far we have 10 of them. We have so far managed to do, we have a plan for 10. We have so far managed to do 3 of them. 2 extra ones are about to be done, like we have for Meru, that we should be able to work on it because the equipment is on the high seas. Once it arrives, we should be able to install it. Then Nakuru, we are going to beef it up. They have 1 bunker and 1 machine. We are going to put another machine there. So we have a plan to be able to put regional cancer centers. We have Kakamega that we are supposed to be operationalizing. We have Kisumu that we are supposed to be operationalizing. But that is subject to resources. We go to the big question, Sam. I do not want to finish before I say this. How do we raise resources to be able to take care of not just cancer, but of the health sector? That is the big question that then we need to be discussing as a country. How do we...
I promised to